So welcome everybody. I'm just going to give a short overview of Diabetes-Free South Carolina and the issues that we face. I'm not going to talk about specific programs that we're doing this morning at all, but I think our wonderful keynote speaker, Dr. Andrea Loftley, who's over there, that I'll introduce shortly, is going to overview some of the things that we're doing. So Andrea, thank you for being here, and I'll be thanking you repeatedly during the day. So this is our annual meeting. First, I want to thank the planning committee. Each year we have a planning committee, and here they are. Ancoma Anderson at the top there is the senior pastor of Welfare Baptist Church. We'll be talking a bit about our faith-based ideas that we're trying to develop for next year later on, and he'll be talking to us as well. Michelle Harris, I think many of you know, wonderful lady who's great with microphones and interviews and radio, and then Rhonda Hill. Rhonda, are you here? Stand up, Rhonda. But we should have everybody. Actually, everybody stand, please. Who's here? Please stand up. Just to Michelle, are you standing up? I don't know. I'm not seeing you. Joy Louie is not with us because she recently had a baby, and she's at MUSC and has been doing great work with us and with the Diabetes Initiative of South Carolina. Myself, Christine, that you just met, is our wonderful new communications person, and Michaela Smith, one of the linchpins of the state diabetes effort over there. Round of applause for all of them. Thank you. And then I want to thank again these two individuals who also could stand up, Sean and Erica. Where are you? I see Sean, Erica. Now, a lot of what we've accomplished is due to really outstanding vision and leadership from these two and from many other people at Blue Cross. I think it was, I was surprised and excited when this whole thing arose, and Sean walked into my office and told me about it now, unbelievably, 5 years ago. But thanks to both of you. And then our own team, there's only 5 of us, but we try to persecute a lot of people all around the state and align efforts and bring people together. So Noreen, are you here? If all of you could also just stand up. I don't see Noreen, she's probably out at the table. Misty, Arthur, our trusty data scientist, morning Arthur, and Christine that you just saw. So I think it's fair to say we have a very cooperative, collegial and cohesive group of people who are genuinely inspired to try to change South Carolina for people with diabetes and try to really make a difference. And we have a lot of challenges. And you're all familiar with this kind of graph. And you can see this is over the past 20 years, since 2004 up through to 2019. The number of people diagnosed, adults diagnosed with diabetes, has been increasing over this period of time. It's not easy to claim that we're winning this fight. We've got to change that. It's not going to happen overnight. It's going to be a course of years and decades and generational effort to turn this train around. But if we don't start today, we'll never get to the destination. We all also know that when you add these numbers up, we've got about 12.5% of people, of adults in South Carolina, diagnosed with diabetes, another 3% who have it but don't know, and 35% with pre-diabetes. That adds up to 51%, more than half the adults in the state affected by something wrong with their blood sugar. And we know that even pre-diabetes doubles the risk for cardiovascular disease, and in most cardiovascular disease is underpinned by some level of insulin resistance. So this is an enormous problem that's hard to exaggerate. Another concerning thing, and I've shown this slide many times now, is, and this comes from the search study, that the fastest increase of type 2 diabetes in the US, fastest percentage increase, is in African American and Native American teenagers. And this presages badly for the future. If we can't turn this around, these teenagers 20 years from now will be in their 30s and going into their 40s, and they will have had 20 years of abnormal metabolic milieu that is going to have driven chronic disease that is very difficult to reverse compared to reversing it early, getting on top of the problem early, dealing with these problems after they've incubated for 20 years silently, accelerating aging, accelerating vascular damage throughout the body. It gets much more difficult to reverse that than to prevent it in the first place. Disparities. Everybody in this room is familiar with disparities, and these are just death rates among different groups in our country. And you can see that Black and Native American death rates from diabetes are vastly higher than those of Hispanic people, and particularly than white people, and above the US average. If we can't get on top of this, we're going to continue to rank poorly in the world for our diabetes outcomes, death rates, morbidity, mortality. This is one of, I think, the most sobering things that we've got to face. It's, you know, if you have an alcoholic in the family or you're an alcoholic yourself, you can't begin to address the problem until you admit the problem that we have. And this is the problem that we have. This is maternal mortality. This is not related to diabetes. This is overall maternal mortality in various different places around the world. And you can see this is maternal deaths per 100,000 live births. So 100,000 is a lot of births. Unfortunately, not many women die, I guess, as a proportion of all the births that take place. But the thing is, this is a surrogate for every other adverse outcome of pregnancy and maternal and infant health. They all show this pattern. And so you can see in Norway, the figure is 2, in the UK it's 7, in Canada it's 10, overall in the US it's 17, and then in South Carolina, overall it's 26, and on the right you see US white people is 13, still 6 times higher than Norway, and US black people it's 43, 21 times higher than Norway, and 3 times higher than white people. And American Indians on the right. So, you know, we have to get to a point where we are no longer prepared as a society, as a community, to accept this kind of death toll that is entirely avoidable. There's nothing different about the biology of a woman in South Carolina from a woman in Norway, and yet we have those differences, and we have to ask why. Here's the percentage of adults with diabetes in G7 countries, the 7 biggest economies in the world. Well, China's not there, but in the Western world. So again, you can see that the percentage of adults with diabetes, women in orange and men in blue, is way higher in the US than in these other countries. And we have to ask ourselves, why is this the case? And then some health outcomes, again, with G7 countries. This is looking at things where we actually excel as a nation in cancer care. If you're going to have cancer, the US is one of the best countries to be in. But that's kind of a reflection of how we do well with serious acute illness that's frightening, that comes on relatively suddenly. Where we don't do well is in this long slog to prevent chronic, non-communicable illness, diabetes, obesity, cardiovascular disease, inflammation, that gradually erode the health of individuals. So on the left side, you can see effective cancer cures in breast cancer, and you can see that this is the percentage 5-year survivals, and the US is top of the list. We do well in these things. But on the right, you see avoidable diabetes admissions per 100,000 people, age and sex standardized. And for that, we come last. And we've got to change our capacity to look after slowly developing chronic disease, or we will continue to have the lowest life expectancy and the highest infant mortality and the highest maternal mortality of all of these G7 countries. Then there's spending. How much money do we spend for the outcomes that we have? It's great about the cancer outcomes, but we're spending twice as much as these other countries on healthcare. And if you look at how much money goes on administrative costs, it's 8 times higher in the US than in any other developed nation per capita. So we have to ask, are we getting value for money here? We're spending all this money, We have problems that are not looking good on a global scale, and certainly not looking good on a personal scale for many of our citizens. And here in South Carolina, unfortunately, we rank somewhere in the 40s for every healthcare outcome for the state, for the nation. So, as I said, Blue Cross amazed me by coming forward with this inspiring idea to do something significant for diabetes in South Carolina 5 years ago. In January, we launched, we're called Diabetes Free South Carolina. Our vision is to win the fight against diabetes, which right now is not happening. And if we go on doing the same things we've been doing for the last 20 years, it isn't going to happen. We have to make radical change if we're really going to make a difference. And I mean radical change, not deck chairs on the Titanic. Our mission is to align and to advocate for actions against diabetes, engaging South Carolinians to lead healthier lives. And really this is all South Carolinians, because 50% of them already have a blood sugar problem, and the other 50%, most of them are going to get one as they get older. So this really is all South Carolinians. And of course, even those who are not affected by it ever in their lives have relatives and friends and work colleagues who are affected. And we've got to get change. So our guiding principles are to promote alignment. And I think this is one of the key things. We tend to have a fragmented, here and there, flash in the pan efforts to address these chronic conditions, when what we need is a cohesive, society-wide, coordinated campaign. If the Russians invaded here tomorrow, we wouldn't be resisting it with church bake sales and philanthropic funds. We would be a united nation against a terrible event. And we need to be the same mindset for dealing with these things that are killing hundreds of thousands of our citizens. Equity is a key issue. It's something that we must solve. If we don't solve it, we ain't going to win. Data and outcome are key. We've got to be able to measure what we're doing and what is the efficacy of it. It's easy to say that. Arthur over there will tell you it's not easy to do. All of us who are working to try to get meaningful outcome data of the things that we do know how difficult it is, how much spongy data is out there, how rigorous we have to be in trying to show that we really are making change. We need sustainable change, not something that's going to be here for 2 or 3 years and then gone. We need to intervene early in life. This is critical. This is known abundantly from lots of different lines of evidence, from the fetal origins of adult disease through to the diabetes control and complications trial. We know that if you establish good health in utero and in childhood and in adolescence and in early adulthood and during pregnancy for women, that you set the scene for the rest of life for everybody affected to be vastly better. And within South Carolina, we need statewide reach. Again, we don't want to be here and there. We need to be everywhere. And if we're going to be everywhere, we've got to build a big team of people to address this problem, not just from the medical point of view, but from the social, the community, and as Ankoma will talk about, the spiritual and mental health of our patients as well. We identified 3 strategic directions. Most of you have heard this before. Number 1, to improve pregnancy outcomes and the health of women with or at risk for diabetes. This earliest stage of life for the baby and a young woman. This is 2 for 1, if you like. It's a crisis event in a person's life where there's a chance to really motivate things and get a lot of knowledge out there about how to live the rest of life healthily. To reduce the lifelong risk of diabetes in children. Very challenging to measure this. We're trying to prevent diabetes 20 or 30 years in the future. But we've got to do this. We've got to improve the health of our kids. Otherwise, we're condemning them to lifelong chronic disease. And then the great big one, because there are so many adults affected, to prevent diabetes and its complications in adult. We're talking 2 million people here who've got it and another 2 million who don't. And it's an enormous challenge of communication, and we're privileged now to have Christine on board to help us with our communications. And I think you can see our brochure on the table, and a lot of that is the work that Christine has done to improve our ability to express ourselves. So thank you, Christine, wherever you are. So the theme of today's talk is Connections for a Diabetes-Free South Carolina. And I just want to throw out some thoughts of things that, as we go through the day and as we have the table discussions, here are some things to think about. First of all, diabetes is a complicated condition that affects every part of the body, physical, mental, and spiritual. It's depressing, it's challenging, it shortens life, it brings threat of blindness and kidney failure. It's a very, people think, well, if I get diabetes, not so bad, could be worse. But when you see the way people react when they actually get that news, it's a heavy piece of news. So we need supportive, multidisciplinary teams where all the different people who are involved in caring for the patient are putting the patient number one and talking to each other and communicating with each other in ways which don't commonly happen in our system. We are too siloed, and we're in an inherently competitive system. It's just, we got to change it. And I think you'll see the MOMS program poster, and we've got many people in the room who are working in the MOMS program, and it's perhaps the most outstanding example of what can be done when you bring together teams to manage a critical situation like pregnancy. We need to implement existing knowledge, and one of my favorite things is that we are not even getting most diabetic patients in the States on statin treatment. The value of statin treatment is incontrovertible. Yes, it raises blood sugar a little bit, but it defends against cardiovascular disease in an enormous way. And unfortunately, in our misinformation society, there's a lot of misleading information out there about statin treatment. Everybody should be on statin unless there's some specific reason that they can't be. And it's cheap and doable, and it's been known for 20 years, but we don't do it. Pyramid of care. This is a concept that I think we're going to come back to probably again and again. We need to deploy a range of people of different backgrounds, different skills, and they all need to be working to the full level of their skills. And that means that we need an enormous number of people at the community level to address the whole of society and educate people in the real communities that are out there. Community health workers, Terry, are important. And then at the top of the pyramid of care, you've got specialists doing inpatient high-tech stuff, but they need to be left to do the inpatient high-tech stuff and not. When I was chief of endocrinology, I got many patient referrals that shouldn't have been coming to us. They should have been managed in the community by the primary care docs. We've got to make sure that the small numbers of people who've got the highest levels of skill are deployed effectively and are deployed to help the people who really need their help. I will talk more about that. Statewide cohesion is obvious and lacking. We've got to change that. We need a whole person, whole community approach addressing physical, mental, and spiritual health. And we need to push for efficient and excellent healthcare, not wasteful mediocrity. And I'm not trying to imply that anybody in this room is doing mediocre healthcare, but our system creates mediocre outcomes in a way through nobody's conscious fault. It's a lack of coordination, a lack of cohesion. And we spend a lot of money reduplicating efforts and missing efficiencies of scale. I mentioned the MOMS program, and this is 2020 and now 2024. This is by no means everybody in the MOMS program. They're all listed on the poster we have in the poster room. But just to remind you what it was like back then when we started. Everybody was running around wearing masks and not being able to see the patients that needed to be seen. Today we're, I hope, looking a little happier. Remember that diabetes is not just blood sugar, it's anything but just blood sugar. There's a host of other things, some of which are listed here. These are just the medical things, and there's all the other things that are not the medical things, the social, the community, the social determinants of health that need to be addressed. There's a pyramid of care where we have community health at the bottom, reaching millions of people at the top. We have inpatient specialists, maybe hundreds of people. The numbers are just illustrative. But we've got to have a coordinated way where we can refer people upwards through this pyramid according to their need and not according to where they live, what race they are, what their income is. We need to get people the care that they need, and we need to deploy it efficiently. So in terms of statewide cohesion, this is a slide I made a couple of years ago that nobody liked, but it was supposed to illustrate a whole bunch of different things that diabetes-free SC is doing so that we can claim we have statewide cohesion. But, you know, we're actually a long way from getting where we need to be. Here are a couple of quotes that I thought might be worth thinking. The top quote is, the top two are from an article published just last month in JAMA. Tragically, little progress has been made in addressing racial and ethnic inequities in healthcare. Movement has been slow, uneven, and inconsistent. And then the second one from the same paper, the US healthcare system has failed to adopt or bring to scale many of the evidence-based solutions for improving health. We know what to do, we just don't do it, and we got to change that. At the bottom is a quote by Dean Schillinger, and I don't know if anybody's read this book, but if you haven't, you should. This is a book that is truly important. I would encourage everybody in this room to get hold of this and read it. And he's addressing the connection between the physician and the patient. And for physician, really, I mean any healthcare provider. If you don't get to know your patient, the first visit, really dig into what's going on, form a proper idea of the whole of that patient's life, past history, social history, current problems. You don't do it in an effective and professional way, all your subsequent visits are compromised because you haven't laid the foundation on which all subsequent care is going to be built. If you fail to make a good foundation, the house you build isn't going to be a good one. So failure to elicit the patient's story, to take a proper, competent history, and to take the time to do it, and benefit from the clinical discoveries and human connections these stories can foster, results in immeasurable suffering and excess healthcare costs. What are we doing to try to get this efficient, excellent healthcare? Well, these are, again, the guiding principles of DFSC, but I think they need to be the guiding principles of everything that we're all doing for all aspects of healthcare in this country. As I said, diabetes, if you know diabetes, you know all of medicine. There's nothing it doesn't affect. These are just the medical things. These don't count the social determinants of health, the mental illness, the depression, the spiritual problems that drive the diabetes epidemic. So that's just, and here's a good Irishman, as usual, with a pithy remark. The problem with communication is the assumption that it has occurred. How often do we realize that? You say something to someone, but they hear something else. Or because their voice is quiet like mine, they don't even hear that you said anything. Or the words you used mean something to me and something different to the person I'm talking to. Always check that your communication has been received. Don't send an email and assume that somebody's read it. Confirm with your patient that the message that you've got by getting them to tell it back to you has been received and understood. So our future strategy, we want to develop and sustain the things that we're doing that are being successful. As I said, this is a years and decades long slog, and if things are working, they're going to work, but it's going to have to be sustained over periods of years. So we want to make the things that we're doing that are successful to continue and to get sustainability. We, in the work that we fund, are constantly after accountability and the measurement of meaningful outcomes. We want to make new investments going into the future to further align, connect people together, complement the things that are already happening. We want to maintain a focus on those guiding principles and our strategic directions, and we want to enhance community engagement, and in doing that, we're working with ANCOMA over there and with others to develop a faith-based initiative. And then we want to get to young people who are future leaders of society, and one way to do that is through colleges, universities, and especially HBCUs, and to get to sororities and other groups that will be able to foment change and really start to address the apathy that exists in society. We are too apathetic as a society about these health outcomes, and as a medical profession, we're way too apathetic about it. We really just get through our day and we don't think the big picture and take responsibility as medical people for what we should be doing to improve our patients' health. So thank you very much.